now.
So a very good evening to all of you, and I, on behalf of Indian Society for Cornea and Cataract Refractive Surgeons, welcome you all in this webinar on ophthalmic procedures, which are commonly performed by the ophthalmologists. And we have with us our president, Professor Jas Bhalla, who is the chief and professor of ophthalmology in the Cataract, Cornea and Refractive Surgery Services at RP Center AIMS. He has numerous publications. He has won various awards, both national and international. Has presented various orations. He was the first Indian to have performed live cataract surgery at ASCRS, and he has received the most coveted Padma Shri from the government by the President of India. And of course, he is our teacher.
We have with us Dr. Rishi Mohan, who did his MBBS from Maulana Azad Medical College in New Delhi, followed by his MD at RP Center and then his DNB and FRCS from the Royal College of Edinburgh. He did his 5 months training in clinical registrarship in phacoemulsification from Prince Charles Eye Unit, King Edward Hospital, Windsor in UK. He has numerous academic awards and won a gold medal and certificate of merit as well for the first position at Delhi University. He also won the Best Resident Award at Dr. RP Center Ophthalmic Society Center for Ophthalmic Sciences. He held numerous positions in various academic bodies. Welcome, Dr. Rishi Mohan.
We have with us Professor Namrata Sharma, who is the chairperson of ISCRS, chairperson scientific committee, and also professor of ophthalmology in the Cornea, Cataract and Refractive Surgery Services at RP Center AIMS. She is very active academically as well as socially. She is the secretary of All India Ophthalmological Society, regional secretary, Asia Pacific Academy of Ophthalmology, secretary, Eye Bank Association of India, and is involved in various academic activities. She's a wonderful teacher, numerous publications, more than 500 in various journals, has various textbooks to her name, and has been conducting numerous instruction courses, both internationally and nationally, a thorough academician, and it is really wonderful to have her in this webinar. We welcome Dr. Namrata.
Thank you, Rajesh.
Rajesh, sir. Join कर लिया मैंने, sorry.
We have with us Dr. Suresh Babu, the professor of ophthalmology, chief of Cornea and Eye Bank, Regional Institute of Ophthalmology, Minto Ophthalmic Hospital, C and RI. Area of interest are infectious keratitis, refractive surgery. He's actively involved in teaching the postgraduates, and he's been participating in various conferences. Welcome, Dr. Babu.
Thank you, sir.
We also have with us Dr. Aditi Ghosh Dastidar, who is a cornea consultant at Netralayam, Kolkata, and also has her own practice in Delhi. She has been trained from Vardhaman Mahavir Medical College and Safdarjung Hospital and Ramanohar Lohiya Hospital in New Delhi. Has done fellowship in cornea, cataract and refractive surgery services from Shankar Netralaya, active member of UC, and has various publications and has delivered various talks. Her areas of interest are dry eye disease, cornea and external eye disease, keratoconus, refractive surgery of the surface, etc. So we welcome Dr. Aditi in this webinar.
Dr. Mayank Agrawal is the consultant at Jindal Eye Hospital in Jaipur. He did his MS Ophthalmology from University of Rajasthan in 2002. His MBBS from SMS Medical College, Jaipur, Rajasthan in 1998. MD from SMS Medical College, Jaipur, Rajasthan, 2001. He's the General Secretary of Jaipur Ophthalmological Society. His areas of interest are cataract, cornea, and refractive. Actively involved in various academics. We welcome Dr. Mayank Agrawal.
Thank you, sir.
We have with us another teacher of mine, Dr. Harsh Kumar, who is currently Director, Glaucoma Services, Center for Sight Group of Hospitals, New Delhi. He has loads of awards. He was a wonderful student during his career, throughout his career. Was awarded Padma Shri by the President of India. We are fortunate to have two of our teachers who have been awarded Padma Shri, and they are here in our session. He has received gold medal in his MBBS career. He received the gold medal when he did his post-graduation. Then he received the Best Senior Resident Award also when he was Senior Resident. Then he worked as a faculty at RP Center in the Glaucoma Services, was the additional professor. when he left and joined Center for Sight. He is formerly President Glaucoma Society of India. He has numerous publications in various journals, international and national. Has performed various innovative techniques, several laser procedures for glaucoma and anterior segment described for the first time in world literature. Has conducted numerous courses successfully, both nationally, internationally. He has performed the most complicated glaucoma procedures, including the valves, shunts, routines, and of course other routine procedures. Was conferred the International Medical Scholar Program Award (ECFMG) fellowship with a fellowship at University of Illinois at Chicago, USA. Has been awarded the Icon of Ethical Healthcare Award at Health Conclave at Chandigarh 2019. And apart from these, there are many other things which, of course, I have edited. And he is a wonderful teacher of teachers. We welcome Dr. Harsh Kumar.
Welcome Dr. Srinivas Joshi, who's the consultant and head VR services at Joshi Eye Hospital. He's had done his MS Ophthalmology from LN Medical College in Belgaum. It is VR training from Steve Charles Retina Institute in Memphis, USA. Surgical VR fellowship from University of Toronto, North America. Pediatric retinal surgeries and Sick Child's Hospital, Toronto. Areas of interest are artificial retina, Argus 2, first US FDA approved bionic eye, Senior Honor Award by ASRX, Boston 2007, awarded prestigious Rake Bucker Oscar Award by the American Society Retina Specialist at Boston, Vancouver, as well as Chicago for 3 consecutive years. Is the International Hero Award by AIOS in 2018 and 2019. He is the reviewer of national and international journals, including AJO, APJO, and IJO. Areas of interest include diabetic retinopathy, macular hull surgeries, retinal detachment, ROP. We welcome Dr. Joshi.
We also have with us Dr. Praveen Subudhi, who is a cornea and refractive surgeon and chief consultant at Ruby Eye Hospital in Orissa. He has done his cornea fellowship from Arvind Eye Hospital, Madurai, has done the ICO fellowship in cornea and refractive surgery at Switzerland. He is the E-Zone representative of FBS AIOS, has performed various live surgeries in state and national conferences. He has 22 publications in various national and international journals and is a reviewer for various journals. He has received the Innovative Award in the field of cornea by Pubindex. He has also received the first prize in AIOS quiz competition at Jaipur 2009. And we welcome Dr. Praveen Subudhi in this webinar.
We also have with us Dr. Ritin Goel, who is a consultant at Goel Eye Institute, New Delhi. He's a cornea fellowship from LV Prasad Eye Institute, Hyderabad, actively managing cornea and ocular disorders, has various papers and lectures in national and international conferences. His areas of interest are lamellar corneal surgeries, corneal cross-linking, and is active in various academic forums. Welcome, Dr. Goel.
Happy to introduce Dr. Mukesh Paryani, young and dynamic ophthalmologist working at HV Desai Eye Hospital, working at HV Desai Eye Institute in Pune. He has completed his DNB ophthalmology from HV Desai and then went on to do his long-term fellowship in cataract and refractive surgery in Narayan Nethralaya, Bangalore. And then he's working as department head of refractive surgery in HV Desai Eye Institute, Pune. He is also consultant of Neo Vision Eye Care, Pune, and has been awarded the prestigious YKC Pandit Award at the MOSCON 2018 and Dr. M.B. Jamwar Nitra Seva Award by Pune Ophthalmic Society in 2019. We welcome Dr. Mukesh Paryani.
Dr. Jas Bhalla, who is the senior consultant and academic in charge, DDU Hospital, New Delhi. His special interest is in cataract and glaucoma. He has many publications in peer-reviewed national as well as international journals. He is presently the General Secretary of Delhi Ophthalmic Society. He is a member of the Scientific Committee of the All India Ophthalmological Society. He is Chairman Scientific Committee of ISM SICS Delhi chapter. He has been awarded IIR-SI Gold Medal in 2019, has been felicitated by the National Eye Bank AIMS 2014 to 2021, has won the R.N. Sabharwal Gold Medal by DOS in 2017, 2018 and 2021. DMA Appreciation Awards, Delhi State Awards, has been applauded by the ISCRIS for his achievements, and as well as in Ophthalmic West, he has Best Paper Award in H.C. Agarwal Trophy by DOS in 2018, and Best Paper Award at Annual DOS Conference in 2019 and 2020. He's conducted various instruction courses at the annual AIOC. Welcome, Dr. Bhalla.
We also have with us Dr. Abhishek Anand, who is a young and dynamic vitreoretinal surgeon working as an assistant professor at RIO IJMS Patna. He has done his training from St. GS Medical College as his MBBS training, and then went on to do his MS Ophthalmology and DNB from Guru Nanak Eye Center, New Delhi. He did his fellowship in VR surgery at Viratnagar Eye Hospital in Lahan, and he is recipient of various awards, which includes Dr. D.K. Prasad Gold Medal and Dr. A.K. Prasad Gold Medal at BOS meeting. And of course, he has also won the Best Poster Award at AO 2010. He has 11 publications in peer-reviewed index journals, has presented his works at various national and international conferences, and his area of interest are pediatric vitreoretinal disorders, myopic macular disorders, suprachoroidal therapeutics, and macular buckling. We welcome Dr. Abhishek Anand. I also have with us Dr. Rajiv Mukherjee, who is my co-moderator, who is the treasurer of ISCRS, director and senior consultant, Mukherjee Eye Clinic, also the visiting professor at Feinberg School of Medicine, USA, an established cornea and phaco surgeon, has various publications and presentations in various conferences. He's also vice chairman of FBS AIOS, and myself, Dr. Rajesh Sinha, honorary general secretary, ISCRS, and professor in the corneal lens and refractive surgery services at RP Center, AIMS. So before we actually start the scientific meeting, I will request our president, Professor J.S. Tityal, to say a few words. So you have to unmute yourself.
Thank you, Rajesh. A very good evening to all of you. And we all know this is our first scientific meeting of this year. Let's hope this year goes in a right manner, which is, let's have a double of 2-2 life in terms of getting everything okay. I would say the journey of 2021 has been tough for everybody, and it's been tough for us also. We could not do the physical meeting of ISCRS, but because of efforts of Dr. Rajesh, Namrata, Rajiv, and Rishi, we could do a lot of most effective webinars through ISCRS platform. And the beginning of this year is also not different. It is, in fact, the beginning is going to be very comprehensive, looking into various aspects of basic procedures, basic clinical diagnostic webinars in future. And along with that, going to do definitely the other areas of mastering the various aspects of ophthalmic practice. If I see this particular program, which has been organized by Dr. Rajesh, is actually getting people from different sectors, right from the ocular surface infection to glaucoma and retina, very common procedures. I think people would definitely like to know the basic aspects to do things correctly in these minor procedures, because they make a lot of effective change in a clinical outcome of these patients. So it will be very nice to know this procedure, which is being done by most of the general practitioners, and the young people who are going to learn this definitely will have a lot of benefits knowing the true aspects of doing correctly these procedures. Apart from the speakers, we have a very nice panel of people going to discuss this. I'm pretty sure this is going to make a very lively session for beginning of this year 2022, and we hope that we'll be doing much more such webinars. If possible, in the God's grace, we can have a physical annual meeting of ISCRS this year. Let's hope this pandemic, as it's rising so steeply, goes down much more faster to save the lives and improve the physical appearance of a country. I hope and pray for all of you to have a safe days ahead. Dr. Rajesh, we can start. Thank you.
Thank you, sir. No, thank you very much for your words of encouragement. And we begin the scientific session. And we have our first speaker, Dr. Suresh Babu, who is the cornea RIO Bangalore. He'll be talking to us about the corneal scraping in microbial keratitis, which is really the mainstay of management in cases of microbial keratitis. Dr. Suresh Babu, please.
Thank you, Dr. Rajesh Sinha and Dr. Namrata Sharma and Dr. Titiyal sir for inviting me for this talk. I'm going to share my screen. The corneal scrapings in microbial keratitis. This is the Minto Ophthalmic Hospital, a very old hospital. We have completed 125 years just last year in the November. I'm proud to be a part of it since 1997 in this hospital. Slit lamp biomicroscopy of a corneal ulcer. What exactly we do? We just define the borders of the ulcer, the depth of the ulcer, involvement of other structures, if any. All treated ulcers look for the healing edges, progressive, or maybe even drug toxicity. Always, it is better to record before beginning any treatments. Daily recordings of the case using color codes and corneal sheets would be useful. Digital photography, which I have found now to be very helpful in objective assessment. Corneal scraping of any microbial ulcers. Why do we need it? Most of the ulcers are treated by good antibiotics which are present in the available in the market in the commercial forms or fortified antibiotics. So is there a need for doing any corneal scraping? Maybe or maybe not. But in few institutions, it has become a standard practice to do corneal scrapings because the institution follows such practices, and also we'll get epidemiological data to find out what type of organisms are present in our society and what are the antibiotics which are useful for it. Also, scrapings would help us to find out the etiological cause, which organism is present in this ulcer. It might be difficult to clinically judge what type of ulcer it is in certain cases. So in such cases, you need to do a corneal scraping to find out. There might be mixed infections. Suppose you might be treating it as a bacterial ulcer, there might be a hidden fungus behind it. Okay, fungus was initially to start with, but a bacteria overtook it. Then there might be a non-healing ulcers despite trying all types of medications. So you need to find out what type of infection is there. What are the advantages of doing a corneal scraping? The advantages are that once you get to know to the organisms, then you might get culture sensitivity, especially in case of bacterial ulcers. So you can target the organisms more effectively. Second, if it's a fungal ulcer, we can give intracameral drugs safely because we know it's a fungal ulcer without blindly trying to give intracameral drugs. So these are the advantages by doing a corneal scraping. And sometimes it's very easy when you start learn to do corneal scrapings and do stains at your own place. It's just an OPD procedure. And sometimes you might need the help of the microbiologist to get to know how to do it. How to do a corneal scraping? First and very important, you should make a clinical diagnosis. Without a clinical diagnosis, it's very difficult to assume what type of ulcer. For these type of ulcers, suppose you are thinking it's as a fungal ulcer, then you need to order a Sabrots dextrose media agar so that you can plate it right there in front of you, or you can have a KOH wet mount, or if it's a bacterial ulcer. So clinical diagnosis is very important. Usually it is done in a slit lamp. Commonly used is Bardpaka blade number 11 or 15, or 23 gauge needle, 25 gauge, 26 or 27. I prefer to go with a 23 gauge needle. Why I say it's a 1-inch needle, disposable needle. We can get a large amount of material using that needle because the bevel is larger. Second, it is thicker, so it is difficult to perforate even in the hands of a novice. So I prefer always to do scrapings with a 23 gauge needle. But whatever instrument you're comfortable with, you can do with it. I would always advocate you not to stain the ulcers because staining will cause the ulcer to turn green or whatever stains that you are using, and you will not be able to differentiate the ulcer initially. Remove the slough and mucoid material because these never usually give you the organisms from there. Take the material from the active edge of the ulcer for both stains and culture. There might be many areas, especially in treated ulcer, where the ulcer is not active. So you have to first learn to differentiate the active one from the healing ulcer. So never take material from the healing edge. Always take it from the active edge of the ulcer. So if the lesion is in the periphery, you can aggressively scrape the lesion so that you can debulk the ulcer. This is a small video that I am going to play. So this is an ulcer. See, it's just off the pupillary area. We are using a 23 gauge 1-inch disposable needle to scrape it, and you can see the bevel how it's trying to take out the material, infectious material. So this material, as soon as this is done in a slit lamp with a speculum, and proparacaine is the anesthetic used. Usually the patients, if you counsel them, they'll be relatively comfortable and they'll cooperate with you. See, it's just lifting off. And in South India, since ours being a tertiary institute, we see a lot of fungal ulcers than bacterial ulcers. So effectively, what we are trying to do is taking material for scraping as well as debridement in this case. Ulcer is almost getting debrided, so that we are debulking the ulcer to a great extent so that the drugs can act in a better manner. That is the material. This material can be used for both culture as well as the stains. So what are the stains that are commonly used? The commonly used stains in our hospital are KOH, that is potassium hydroxide. Usually 10% is what the books recommend, but I have a secret from microbiology. They recommend to use 40% because it dissolves the tissue very easily, and the KOH fungal filaments are easily made out. KOH in addition will tell us if there's acanthamoeba, if there is nocardia. Then there's gram stain which can be done, which is usually done in our lab. It will tell us about the bacteria, gram positive, gram negative, then about acanthamoeba and about fungal elements. Then the Giemsa stain, similarly, which we usually don't do, which we usually take to our microbiologist to get it done. And the acid fast stains such as Zeal-Nielsen, which will tell us about the mycobacterium as well as the nocardia. And chalcofluor white and acridine orange, these are the stains which are used, but these require fluorescent microscopes, very costly, but they are very accurate, and bigger institutes which have these type of fluorescent microscopes can be done. Another thing, with this corneal tissues, we can do PCR also if you have got facilities in your institute or the place where you are giving to your this one. Culture, what is the cultures that are used? So once you know what type of clinically you have made a diagnosis, you can either use a blood agar or chocolate agar if it's a bacterial one, or thioglycolide broth. If it's a fungal one, it's Sabarod's dextrose agar is used. If you're suspecting acanthamoeba, you have to tell your microbiologist a day before so that he can prepare that non-nutrient agar with E. coli. The other medias are depending upon what organisms you are suspecting. In bacterial ulcers and acanthamoeba, only the edges are scraped. Whereas in fungal keratitis, scraping and debridement is done. We do debulk as much as possible. We create and maintain an epithelial defect to permit better drug penetration, especially natamycin, which is the drug of choice that we are using in our institute. So as long as an epithelial defect is there, the drug starts acting on this fungus. These are a few pictures that we are going to show. This is an ulcer which is, you can see a total corneal ulcer. This is probably a bacterial ulcer. Such ulcers we don't debride in a slit lamp. We take them to the OT and take the material for when we do a therapeutic keratoplasty and send that button for culture as well as stains. So these are not done on a slit lamp. This is a typical fungal corneal ulcer. You can see this raised margins, feathery edges, and you can see a KOH which has been done, which has turned out positive here. And this is how the in the low power that the KOH fungal filaments appear. The same filaments appear in the higher power. It's very easy. You can get this result within 5 minutes. So you can make the patient wait in your OPD clinic and just get the results. KOH is very, very easy, and mind you, these results are so very good. So how does post and pre debridement occur? So when you see an ulcer here, See the post debridement. Here you can not even see the pupil in this area. Just 10 minutes after debridement, you can see the pupil. 90 to 95% of the infection has been taken care of. And these patients especially do well with napamycin. This is a case which we had in our department, that this was a ulcer which was perforated. You can see a small perforation in this area, and this was responding to treatment, and somehow it stopped responding. Then I said that why don't we go ahead and take debride this part and send it for culture. When we did KOH, surprisingly, this bacterial ulcer turned out to be a fungal component. So this is how there can be mixed infections which you might miss out if you don't scrape it. This is another bad fungal ulcer. You can see the anterior stromal part has been taken care of, whereas you have an endothelial plaques and hypopyon. And another fungal ulcer similarly. And this is the fungal ulcer debridement which I showed you the video. You can see despite debridement, you can see an endothelial plaque and hypopyon. So this is how these corneal scrapings help us, and debridement helps us in microbial keratitis. This is a corneal charts that we do in our institute. Thank you very much.
Very nice presentation, Dr. Suresh. It was wonderful to see how nicely and how minutely you have covered all those points which are so essential in order to get a correct diagnosis as far as microbe is concerned. Would like to have comment from Dr. Praveen Subudhi, who is the panelist for this talk.
Thank you, sir. Thank you, sir, Dr. Rajesh sir, and Dr. Namrata madam for giving me this opportunity. Dr. Suresh Babu has completely covered the most important points of corneal scraping and microbial keratitis, and this is very, very important for general practitioners, because I am running a clinic where I see general ophthalmology, where I don't get much time to do much of specialty work. But I have in my OPD, I have a microscope, compound microscope, where I scrape these ulcers and see under the microscope in the KOH and tell my pathologist to go for Gansin. In simple, these two staining techniques can give you the idea of whether which is the ulcer, what are the type of ulcer, and to prevent any form of polypharmacy. Because what happens in rural places, there's still the practice of going for polypharmacy. They give empirical therapy of antibiotic, give the steroids, and even antifungals. I have seen combination of all the drugs are being given to the patient. And these patients have a lot of misuse. And if this thing can be going, if this information of scraping, if you could teach our rural ophthalmologists, it will be a big help for the patients to reduce the polypharmacy. And coming to the scraping techniques, sir has told whatever technique which suits you can perform. I would prefer a 15 blade, which is I do it under the supine position. I just make my chairs in the supine position and do the scraping. And it helps me because it makes the patient more comfortable. I have a dedicated speculum. I put the speculum in the OPD and just do a little bit of scraping and see under the KOH microscope. Because clinically, you can diagnose whether it's a fungal ulcer or a bacterial ulcer, because most of the cases you can have with a clinical picture, you can diagnose, and accordingly, you can go for the corneal scraping and staining techniques. So this is the thing I want to say.
Thank you. Thank you, Dr. Praveen. Any comments from any of the panelists, Jal sir, Namrata, Rajiv?
I think he covered very, very nicely. I think there are 3 or 4 things which are very important in our ulcer management, rightly covered. First is which cases to be scraped. I think there is no doubt that every case in a first visit or first contact should be scraped, small or big. Or those cases who are not responding to your treatment, because you need to have a re-diagnosis of these patients. As you saw in one of the cases, not responding to your initial treatment, that might change after diagnosing with the scraping material. And third is those cases where you actually have been seeing these patients for a long time, chronic cases where things might change, the bacterial or fungal or a mixed ulcers. So any primary case, secondary, those are not responding to your treatment. And most importantly, we always tell if you have a patient on a treatment, then you stop the antimicrobials for at least 24 hours to 48 hours, then do a scraping in these patients. and those patient has to be under your direct supervision. Second was how to scrape. He beautifully covered that area. People do with the various techniques. Idea is to have a adequate material coming for both for culture as well as for your smear examination. And third important is to basically to confirm your diagnosis, which you rightly pointed out, the clinical diagnosis, to support that and support the initial treatment which was started in these cases. Second is to have a very authentic, objective report in your hand, because sometimes these patients don't do well despite all treatments. There, if you have in your hand, this is the objective record which you got from your culture or scraping, that puts us in a right foot to really discuss the treatment line with the patient and change the medications accordingly. I think apart from the initial, fungal ulcer, you rightly so, you have to, in fact, take out the as much as infected possible, especially in those cases where you have a deep ulcer. For superficial ulcer, we don't have to debride that much because you'll have a good outcome as such. Those days are gone where, apart from debulking the fungal ulcer, we used to do cauterization on the spot. And I know that carbolic cautery those days used to be very common. We used to burn out the entire ulcer area, in fact, in those days, because we didn't have a good antifungal at that time. We had to get into a different things, silver sulfadiazine type of things in those days. But natamycin is a good medication. Dr. Namrata will tell us that we have a new Natasol which can penetrate through the cornea now. So things have changed, and that's because we can identify these organisms in a better way. And best would be to have now a culture sensitivity of these fungus which we grow. That will totally change the customization of treatment in our corneal ulcer also in our country.
Thank you, sir. Any other comment?
I think Rajiv, you speak.
Go ahead, ma'am. Go ahead.
I just
Just a minute.
I just thought it was an excellent presentation, a very practical presentation with examples which were there, and I completely agree with Dr. Suresh Babu that debridement has a role to play, which has not been highlighted much. Even in the study which was done by Arvind, they said that debridement doesn't help much. But I think the case that he showed was so beautifully elicited that debridement does have a role to play. The only cases perhaps where we can get away without
Aditi, can you unshare?
Without doing a scrape would be ulcers which are less than 3 millimeters in size and ulcers which are not involving the visual axis. So perhaps there you can just give empirical therapy, but all others in our center as well also, because it's just customary to do corneal scrapes for all patients. And again, although BP knife is the one which is recommended for scrapes, but somehow even we are using needles only, and they seem to work very well, as was again shown in that excellent video by Dr. Suresh Babu.
Rajiv?
I have one question here. So in case of deep ulcers, and if you see in the OPD and you scrape it and it perforates, so what you do next?
Sir, if any person is actively doing debridement, especially aggressive debridement for fungal corneal ulcers, you will definitely have 1 or 2 perforations. Mind you, in the beginning stage, you are really going to have it. So the only thing that I would like to do is I would like to put my cyanoacrylate glue. And in Karnataka, in Bangalore, both our institute, I don't want to name another big institute, we use Fevikwik, which is available as 5 rupees one, cheaply available. It is a cyanoacrylate, and in 2006 we demonstrated it is bacteriostatic. Okay, we load it onto a tuberculin syringe, change the needle, and on the slit lamp only with speculum on, we apply the glue.
अभी तो बंद हो गया, अभी बंद हो गया.
Rajiv.
We don't even need to use this whatever costly glues which are coming in the market. Till today, from last 15 years, I think we are used with Fevikwik only. Hopefully, the Fevikwik company doesn't know about it and doesn't increase the price.
I wanted to come in keeping in mind the interest of corneal surgeons or people who are dealing with corneal infections and wanted to do scrapings and sitting in the periphery who don't have too many amenities. So given the choice between GIMSA, GRAM and KOH, if you have to do only one, what would you consider the most important? And which one would you take up? Dr. Suresh Babu and Dr. Praveen, if you can just tell us.
Sir, it depends upon where you are, sir. If you are in a place where we see a lot of fungal infections in a periphery or at a place where you are you used to seeing a lot of fungus, I would like to do KOH first. KOH would be my choice. Okay, or if you're in a place where you're seeing a lot of bacterial ulcers, then grams would be my choice. Okay, this is how. That's why we need to have an epidemiological basis on what type of ulcers you are seeing at your place. Because without that, it's very difficult to answer your question. But given a choice, my first choice in our institute in Bangalore would be KOH.
Praveen?
Yes, sir, I completely agree with Dr. Suresh Babu, because in my place in Orissa, majority of the population is in the rural population of the farmers. And because of the vegetative injury, they get these ulcers. And most of the ulcers are fungus. So around 90% of the ulcers are fungus. So if you have a KOH, 10% KOH and a compound microscope in your rural practice, that will be more than enough to treat 90% of the ulcers. And only the 10% of them who doesn't respond can be referred to the higher institute.
So fantastic. The take-home message here would be that KOH, wherever you are, whatever the epidemiology, is the one and the only thing. If you can do it, because that will tell you whether it's fungal or anything else.
Yeah, it will rule out fungus, and then you have the bacterial thing there to treat by antibacterials. So a wonderful message, and we move on to the next.
Dr. Harsh wants to come in.
Rajesh,
Yes, sir.
I just wanted to know that some of you must be the members of the higher societies, and Suresh Babu told a beautiful trick with the Fevikwik thing, but can you officially recommend it?
Officially, it will be difficult to recommend, I guess.
I have been doing Fevikwik for a very, very long time, and I have talked about it in some forums.
Have anybody of you published it?
I think if somebody publishes it, then it still has an authenticity, and you can still.
Madam, one thing I have studied on the Fevikwik is that it is cyanoacrylate.
Okay.
N-butyl cyanoacrylate, I cannot guarantee you, but it is cyanoacrylate. Second thing, in 2006, we presented in our Karnataka Ophthalmic Society. We had a video there. In that, for that video, we did a bacterial study. We cultured it. It is bacteriostatic. So it's safe to use it, and 5 rupees you can use it one for each patient. There's no problem at all. You just need a tuberculin syringe, speculum, and 26 gauge needle. That's all.
No, Suresh, that is very good. But doing something officially and doing something the trick. We do a lot of tricks. That's fine. But do you make it sterile by any technique?
No, sir. We have just put it into a culture plate, both blood agar and chocolate agar, and try to grow organisms through it. It is bacteriostatic. In fact, nothing grows surrounding it.
So have you published it?
No, sir. Unfortunately, I have not published.
So please publish it, because you are doing this procedure so often, and it will help everybody. Because then they can go back and say, yes, we did it because this was being done like this.
Yeah, it's a wonderful suggestion, because in order to advocate something, I mean, we can do a lot of things, but in order to advocate something, perhaps some evidence-based, advocacy, can be done. So maybe publishing this series will be a good idea, Suresh.
Yeah. Well taken.
We move on to the next speaker, and that is Dr. Aditi Ghosh Dastidar, who will be talking about acute chemical burns, minimizing damage.
Thank you so much, sir. At the outset, I would like to thank TKL sir, Rajesh sir, Namrata ma'am, and team ICKRS for including me in today's session. I will be speaking about chemical burns to minimize damage. I hope the slides are visible.
Yeah.
Okay. Yeah. So we all know that chemical injury is a true ophthalmic emergency. Not only it produces extensive damage to the surface, cornea, anterior segment, but also can lead to permanent unilateral or bilateral visual impairment. And we get a lot of cases, accidental in children, young adults, occupational hazards, not using protective gear, or even assault related like vitreal. So even the medical legal aspect must be covered in during the management of such cases. So we know that it depends on the type of agent, the pH, the reaction with the tissue, concentration, volume, temperature, duration of the contact, how much intraocularly it has penetrated, its ability to penetrate, any added thermal mechanical component, and not to forget retention of particulate chemical matter on the surface or intraocularly, which we can miss very frequently during the OPD examination. So the golden rule that we have always studied and remember that acid injury causes denaturation of and precipitation of proteins on contact, and alkali causes liquefactive necrosis. So alkali is more harmful. This is just for the budding ophthalmologist. We should know the type of agents that are very frequently we deal with such chemical injury. Calcium hydroxide, this lime plaster, it is one thing which is very dreadful, and I'll be showing one or two of the cases. I remember a very beautiful video made by Namrata ma'am regarding the lime particle, that lime packets, tuna injuries in children. So we have the classifications to help us with the grading as well as the prognosis. Nowadays, mostly we all use DUAS. So it has simplified the idea of what all prognosis we can guarantee. But not always we get out of the book pictures. We get a mix and match of all, and it also depends on what stage the patient is coming to you, whether it is a treatment naive eye or already some prior treatment has been done by previous places. So if it's one of the cases where swift irrigation has to be started, the management has to be started before taking a thorough history or even a thorough prior examination. So just for the budding ophthalmologist, take care, see the periocular examination, the lid and adnexa, evert and double evert the lid as a rule of thumb. Do not forget that. Impacted retained particulate matters of tuna lime plaques in cornices are very easily missed. So these has to be taken in mind. Dismay retractor is a boon in such cases. Try to use that. If your residents, just try to practice it from now only. Conjunctiva, fluorescent staining, the bulbar and tarsal conjunctiva is very important. White eye, porcelain eye in acute stage is bad sign. Do not forget the underlying scleral status, ischemia, thinning, and melt. So limbus chemosis sometimes hides the underlying ischemia in a few stages, so that has to be taken into account. Cornea, as very rightly said, as a cornea specialist, we love to see the cornea first unstained and then only we proceed to stain, because we tend to miss out so many things if we stain it just without seeing it unstained. And also the stromal edema, any infection, any desmetocele or melt. AC reaction, IOP, there's usually a bimodal peak, and posterior segment should a very gentle B scan or indirect ophthalmoscopy if the cornea permits. So coming on to the management, so ocular chemical injury, the management goals are immediate or emergency management followed by acute phase and then chronic. So I work in both a multi-speciality eye care center as well as a multi-speciality hospital. So where the junior residents are the first ones to come into contact when the patient comes in the casualty. So message for all of them: in immediate, remove the toxic or inciting agent. So urgent, immediate, copious irrigation with whatever you have. Removal of the residual particle if you can, do it yourself or ask your seniors to help. Check the whole cul-de-sac. Evert and double evert as a rule of thumb. So do a thorough irrigation. If you have pH strips at your disposal, then check with till the pH strip is neutralized. So now the acute phase management goal, Iyer et al. Have very beautifully described it as the management of the eyes and E's. Here we can also think of it as removal of the inciting or the toxic agent, epithelial barrier restoration, inflammation, infection control, prevent the stromal breakdown, taking care of the ischemia, so re-establishing the vascular supply, taking care of the intraocular pressure, and exposure has to be addressed. Chronic phase management is mostly rehabilitation of vision when the eye is quite well epithelialized, when the stem cell status has to be taken care of, the complication prevention, exposure correction, and sequelae management. So mostly I'll be taking acute phase management in my talk. So again, remove the agent, which is very important. I'll show a video of how to remove line particle after this. Epithelial barrier restoration. Nowadays, we have few things in our OPD which are very useful, like a bandage contact lens. So if you don't have amniotic membrane, not all everyone has amniotic membrane in their OT. So if you can't do anything, you can put a PCL, start the medical management, and refer to a higher center or a cornea specialist without any further delay. Medical management, we all know the principles, and the treatment, the prescriptions are pretty same in all the centers, primary and tertiary. But the surgical techniques are actually not very difficult. They are very easy. It has to be done in the right way. So something like taking care of the ischemia, like by tenoplasty along with amniotic membrane, taking care of the perforation, as Sir beautifully said, with the cyanoacrylate glue. So we do get those desmetosceles, the small perforation, which can be taken care on the slit lamp only by applying a cyanoacrylate glue and BCL. And then obviously you can do this, and then you can refer it to the higher center where they can take care by a patch graft or a keratoplasty. So here's a very shortened treatment protocol, medical management. So the liquid doesn't matter, but do it very thoroughly and immediately. Reduction of the inflammation. So medical management, we all know it is pretty common. We should know the mechanism of action, reduction of the inflammation, epithelial barrier restoration, lubrication. Again, beautiful articles from RP Center regarding autologous serum and umbilical serum comparison. Amniotic membrane transplant, a very simple but very useful procedure. I'll show the video of this. And then in medical treatment only, we use tetracycline, that is doxy, which inhibits the matrix metalloproteinase enzymatic proteolysis. We can use citrate, which causes chelation of the calcium ions, or ascorbic acid, which is a cofactor for collagenosynthesis. So in short, we have to prevent collagenolytic process and promote collagenosynthesis. So coming on to BCL, which I've already spoken about, what is it? It makes a barrier between the raw unepithelialized surfaces, prevents mechanical friction, promotes epithelial cell migration. It is a very useful for pain relief. And if we get large diameters, then it even prevents early symblepharon formation. We have to give a topical antibiotic to avoid infection prophylactically. So now the surgical management. So let's have a look of in few cases. So here we can see these are the line particles, very easily missed because of the scar, but if we can see on the zoomed picture. So this was pretty superficial. So this was removed via debridement, but not always are we so lucky. Sometimes they are in deeper layers as well. So for such cases, especially in children who are playing with lime packets, EUA is a boon. We have to take them up for examination under anesthesia so that we have a good exposure of the cardiac side. We can evert, double evert, take traction sutures, check it properly, remove all the necrotic material, the remnant particulate tuna material from the ocular surface and intraocular. So here we can see, so quite only not the bulbar aspect, we have to take care of this. And sometimes these things go intraocularly and can be very easily missed. So if we can see, even when we are doing the cleanout and pedicle, we could find few particles of lime. I'll just show, and which we will remove. Any ischemic white looking area has to be removed to promote better epithelialization. And then amniotic membrane, I'll show, this is lid to lid. Here we are taking sutures in the lid and then putting a BCL followed by tarsorrhaphy. So a little bit about amniotic membrane. It can be compared as a biological bandage. It is secured to the bare surface with the stromal side, which is a sticky side down with help of fibrin glue. If you do not have fibrin glue, you can very easily use purse string sutures for it and use a BCL to cover it. So the epithelial surface of amniotic membrane acts as a basement membrane for promotion of the cell migration, whereas the stromal side has all the anti-inflammatory action which suppresses the inflammation and neovascularization. So here we can see the amniotic membrane. So check it with a Wexel. So if it sticks, that is the stromal side. So we put the stromal side down and the epithelial side, which is not sticking, that side up. Tarsorrhaphy, very easily anyone can do it from our residency days only. So what it does is closure of the eyelid. It reduces the exposure area, decreases evaporation, decreases the lid related friction. So if you're not very sure whether you can manage the perforation or the ischemia, do a tarsorrhaphy, start on medical management, and refer as soon as possible. Tenonplasty, it is a savior indeed, but so what it does is the first step to prevent corneoscleral melt. We cannot keep the sclera ischemic. We have to take care of the vascular pedicle to promote the corneal and conjunctival epithelialization and reconstruction. So here's a short video where we'll take care of both the tenonplasty and amniotic membrane. So here we can see this was not a treatment naive eye. So we can see the conjunctiva had adhered. So we are making a plane, we are separating the conjunctiva and tenon. So it is very important to get a right plane of the tenon pedicle. It should be tension free. You can get relaxation cuts. Otherwise, when you pull it, there will be potential for shortening in future. So we have taken out the tenon pedicle, and now we are covering the ischemic scleral part with it with fibrin glue. I like to take limbal sutures as well, just to be more careful. And here, amniotic membrane, very simple procedure, just checking it with the vexil. So it was the correct position. Put it with the fibrin glue. You can take a purse string suture if you do not have fibrin glue, and then put a BCL. In some cases, you can do tarsorrhaphy as well. So this was a case where the patient had this picture on presentation, and this is the follow-up at 1 year. So sometimes we do get these patients with corneal perforation as well, as small as desmatocele or a small or a large one, where we need tectonic keratoplasty at the first sitting only. So yes, glue BCL indeed. So I think even I'll start doing, and maybe we can add to the publication. Tenon patch graft, a boon, especially in the COVID time, it was really helpful because we didn't have a lot of tissues in such small cases, or small patch graft, or even large tectonic graft. It depends on the severity and the grade of the patient presenting. So here's a video where we can see the patient also had a perforation. So we took a corneal graft only, covering even the thin scleral area as well as the perforated corneal part where there was iris prolapse, followed by tenonplasty, amniotic membrane, and BCL. So this was a presentation of the patient with scleral ischemia, scleral thinning, corneal perforation. We went ahead with the graft and tenonplasty, amniotic membrane. This is a 1 year follow-up of the patient with a 6/9 BCA vision. Obviously, he will require secondary procedures. Sometimes the cornea is not involved, but there's a scleral ischemia or scleral melt. In such cases, we can go ahead with scleral patch graft along with covering it up with a tenon pedicle, because we need a vascular element to cover it up. Even after a lot of the correct management, also we do get a lot of sequelae in chemical injury patients, but then these all can be managed. The primary aim of the treatment is globe salvage, and then we take care of visual rehabilitation and surface reconstruction. So chronic management goals, I'll not go into details, but yes, we have to take care of the epithelialized surface and whether the eye is quiet or not, and then we can go for visual rehabilitation. SLET, obviously we have to mention this. Thanks to Dr. Virendra Sangwan, we have this beautiful procedure which we do in chronic cases. There are two schools of thoughts of using SLET as a SLET during acute or not. So not going into the details of that, but it is very important in early surface epithelialization, prevents PD, decreases the neovascularization, scarring, and delays the need of keratoplasty in such cases. And last, and for visual rehabilitation, obviously now we have pros lenses, and later on when the eye is quiet, we can definitely go ahead with keratoplasty depending on the grade of the scar. And the light at the end of the tunnel, keratoprosthesis in the severe patients. So to conclude, there is a paradigm shift in management of ocular burn at cellular and molecular level. So the key is it requires immediate intervention, small and swift procedures. So the good news stories in medicine are early detection and early intervention. I would like to thank all the my patients and their patients. Thank you so much.
Thank you, Dr. Aditi. It was wonderful coverage of how to minimize damage in chemical injury.
Thank you so much, sir.
Who is again another young and dynamic cornea person from Delhi, and I would like to have his comment.
Thanks, Dr. Rajesh, for having me here. Excellent presentation, Dr. Ghosh. I think you covered a very vast topic in a very short amount of time.
Thank you.
Fantastic. It was
so
really nice. So if I can add a couple of things to your presentation, I think the point that we really need to impress on someone who's dealing with acute chemical burns is that the use of we need to be really generous with the use of topical steroids. The eye is inflamed, it's burning. So we need to put a lot of steroids in this eye. This question keeps coming up that if I give too much steroids, will I land up with a melt or not? When there is fire, you need to put off the fire, and steroids is what is going to put the inflammation down. And as Dr. Aditi perfectly pointed out, the main goal is epithelialization, symblepharon formation, any other sequelae, they can be taken care of much later. The main culprit is the lack of epithelialization. If our cornea and ocular surface is not epithelializing, whatever we are doing is going to go waste. AMG really helps. And I think you've shown in all your videos the correct, beautiful technique of doing AMG. It really helps. But at the primary level, if you don't have an AMG available, the simplest things would be to use a lot of topical steroids, get rid of the inciting agent, and do a tarsorrhaphy. Tarsorrhaphy is something that is very basic. Anyone can do it, no matter how rural or how urban you are in. And there is no harm, there is no overkill with tarsorrhaphy. It's a reversible procedure. You can do it for anyone.
So true.
Thank you, Dr. Ritin. Any other comment?
I think it was an excellent presentation, Aditi. It covered everything, left nothing at all.
Thank you so much.
Like Ritin said, I think very essential to wash it out. That is the most important thing, that you should wash it out. Even if you have nothing, then it could be just clean water and it should be washed out completely. The role of AMG cannot be emphasized more as you did, because it also helps in your SLET. Because when you do your SLET procedure, any limbal stem cell procedure, if a previous AMG has been done, the cleavage planes are much better. The panels is very well defined, and as soon as you remove the panels, then you will see a clear cornea underneath. So if AMG has been done previously, it really helps in that also. And I think if you ask me what is the best thing for acute cases, I would say cord serum. But cord serum is certainly not available at all places, only present, is only in the institutional regions, and mainly for research purposes. Because in all the studies now we have shown that cord serum outscores AMG, and whether it is inflammation or it is vascularization, in all kinds of burns, whether they are mild, moderate or severe burns, only thing is the availability is an issue. Plus in these already inflamed eyes, you don't have to do surgery. So it's a non-invasive, non-surgical procedure, and all you have to put is drops. You don't have to do any surgery. But of course, availability is an issue, which would always be, because it cannot be available everywhere.
Yeah, so very well pointed out. And we move on to the next talk, which is again a very, very pertinent and very important talk, which is on YAG capsulotomy, which we do day in, day out. And we would like to know from Dr. Mayank that how exactly we should do it and when exactly we should do it. So all that you should know about YAG capsulotomy from Dr. Mayank. Dr. Mayank, can you share your slides?
So Dr. Mayank has joined, but we can't hear him. Now we can see him.
Yeah.
Hi, Mayank. Yeah.
Hi. Good evening, everyone. And thanks for inviting me on this panel. I'm pretty new to these things, not a tech savvy. Are my slides visible now?
Yeah, yeah.
So it is.
Slideshow. Make it slideshow.
Yeah. I'm just making it. Yeah. So I'll be speaking on basically use of ND-YAG laser when and how. So a bit of history that this ND-YAG is neodymium yttrium argon garnet, aluminum garnet. It's 1064 solid state laser, which is being delivered in a higher pulse mode, power pulse mode. The optical breakdown results in ionization or plasma formation in the ocular tissue, and this plasma formation then causes acoustic and shock waves that disrupts the tissue. There are multifactorial uses of ND-YAG with widespread, most commonly in posterior capsular opacification, using for peripheral iridotomies, capsular block syndrome, phimosis, and to cut the vitreous strands in the anterior chamber, disruption of anterior hyaloid phase in malignant glaucoma, and cyclophotoablation in the ciliary body. Draining the premacular subhyaloid hemorrhage, PRP can be done with a frequency doubled Nd:YAG laser, and treatment of recurrent corneal erosions or vitreous floaters has been tried. So PCO is the most common complication of any cataract surgery by any method. It basically forms because of formation of opaque secondary membranes by active lens epithelial proliferations, transformation of lens epithelial cells into fibroblasts and contractile elements, and collagen deposition. These anterior lens epithelial cells proliferates, and they go to the site where anterior and posterior capsules are adhered, and then contraction causes the myoblastic features to cause the wrinkling of the posterior capsule. There are few pictures. This fine fibrosis does not require any treatment because it is not hindering any vision. This diffuse fibrosis definitely should be YAG capped. These are Elshing spurs formed by the proliferation of the lens epithelial cell in sheets. These wrinkles are because of the haptics of the IOLs, and these are fine wrinkles. Fine wrinkles need not to be addressed, but yes, broad wrinkles should be lasered. Contraindications for YAG cap, which involves the corneal scars or irregularities or edema that interferes with target visualization or make optical breakdown unpredictable, and inadequate stability of the eye. A relative contraindication, glass intraocular lens, which are no more in use. We have never seen these glass intraocular lenses in my career. If the case has a suspected or known case of CME with active intraocular inflammation, or in cases of high risk of retinal detachment, we should stay away from YAG, or it should be done when it is really necessary or visually challenging. So we should use minimum of energy. We should identify and cut across the tension lines of the capsules, try to make a cruciate opening, and clean up any residual tags and free the tags. This is how a cruciate opening is made, starting from 12 o'clock. Give the first shot at the periphery, extending down up to the 6 o'clock, and then enlarging it into towards the 3 o'clock and 9 o'clock. So this gives you a diamond-shaped opening. So before starting, I'm not having any camera on my YAG machine. So I've recorded it with my mobile. So first you turn on the machine, start the laser, check that it has been booted properly. There are 3-4 things. The pulses can be set from 1 to 3, and for YAG capsulotomy, I usually use a single pulse. And energy we use to minimum, say 1 to 2 millijoules. So just reduce the energy. It's 2.1. It's okay to me. When the machine has started, it remains in the standby mode. You press the button, and now it is ready to shoot. Always, before trying it on the patient, first try it on a piece of paper that the shot is being correctly delivered. You focus it. I use this Amsler grid and make a point there, and I used to see that the aiming beam is working perfectly, and the shot is going on to that perfect spot where I want. This is the adjustment of the posterior offset. This is very important to adjust. I normally keep at 250 posterior offset because the acoustic waves goes in front and causes lens pitting. So I keep it at 250. The range is between 150 anterior to 500 posterior. Anterior is only used for when we have to puncture the anterior capsule or any membrane in front of the lens. Adjust the magnification as per your comfortability. I usually do it at a 16 magnification. Use a diffuse light, and using the helium neon aiming beam, you just focus it there and shoot. This is how the Abraham lens is being used. You put a coupling solution that may be a viscoelastic or any of the gels. Fill it completely. Try to avoid any sort of air bubbles into it. And hold it firmly between your thumb and a finger. Place the patient onto the slit lamp, and the head position should be straight. Ask the patient to look down and insert the lens into the lower fornix first. Ask the patient to keep looking down only, and then firmly oppose it with the cornea. There should not be any air bubble into it. Uses of Abraham lens fairly reduces the energy level. I use it for my peripheral iridotomies, where I can do these iridotomies at an energy level of 2 to 3 millijoules only. Otherwise, I have to use an energy level of 6 millijoules. This is basically, it increases the convergence angle to 24 degrees from 16 and decreases the area of laser at posterior capsule to 14 micron from 21 micron. We should take care of the capsulotomy size. It should be as large as the pupil in the isotopic conditions. Small openings are preferred in cases where there is a high risk of retinal detachment and in dense membranes where it is analogous to those of a small pupil. Anti-capsulotomy, as I said, it is used in capsular block syndrome, where a shot is being given away from the optics of the lens to allow the trapped material to drain. Or in cases of phimosis, radial cuts can be given. Peripheral iridotomy has replaced surgical iridectomies. It's a prophylactic treatment and very easy to do. Vitreolysis can be done by disrupting the anterior hyaloid phase for malignant glaucoma, or in case of vitreous tags present in pseudophakic and aphakic eyes, which is incarcerated into the wound, that can be vitreolyzed by using this ND-YAG laser. I haven't used for this corneal stromal reinforcement, but yes, can be used there also. There are few complications associated with this, most common being an elevated IOP. In majority of the cases, from 15 to 67% of the eyes, there is a rise of 2 to 10 millimeter of mercury. And this is basically because of the capsular debris, acute inflammatory cells, liquid vitreous, and shockwave damage to the trabecular meshwork. CME is another dreaded complication, which is there in 0.5 to 2.5% of the eyes, ranging from 3 weeks to 11 months after the capsulotomy. And the best way to avoid is to have a larger gap between the IOL surgery and a YAG capsulotomy. There is a 4-fold increase in the risk of retinal detachment after a laser procedure, laser ND-YAG posterior capsulotomy. It is seen in 0.08 to 3.6% of the eyes. Myopia, history of retinal detachment in the other eye, younger age, and male sex are risk factor following posterior capsulotomy. IOL damage is very common, seen in 15 to 33% of the eyes during laser capsulotomy. The type and extent of the IOL damage depend on the material used, and the damage threshold is lowest for silicon, intermediate for PMMA, and highest for acrylic materials. The cases of endophthalmitis has been reported after ND-YAG laser. It has been proposed that the propionectum bacterium acnes have created opportunity for organism to go, which are present into the capsule, to go into the vitreous and develop endophthalmitis. The other complications includes iritis, macular holes, and some loss of the corneal endothelial cells. Thank you, sir.
Thank you, Dr. Mayank. Very well covered everything on YAG capsulotomy. Would like to have comments from Dr. Mukesh Paryani on this very useful procedure.
So that's a very elaborative talk Sir has given on the YAG capsulotomy, and almost covering everything. Just a few points that yes, we have to assess the macula before we are going ahead with the YAG capsulotomy, because most of these patients might have some other macular pathology, and the moment we go ahead with the YAG laser, if there is any presence of a subtle cystoid macular edema, there are some chances of flaring it up. And axial length more than 24 millimeter is a high risk factor for again developing a retinal detachment. Up to 2% it has been quoted in some papers. a size of the rexus of more than size of the YAG of more than 3.9 millimeter is associated with higher risk of a post-operative hyperopic shift. Almost all YAG capsulotomy to a certain extent they cause a hyperopic shift, but if it's really large, like it's more than 3.9 as reported in some papers, the hyperopic shift is a little more common in these patients. So yes, sir, this is the few inputs that I had. Otherwise, sir has covered it absolutely in elaborative fashion. Nothing more to add.
Thank you, Dr. Mukesh. Any other comment from any of the panelists?
Okay, Rajesh. Yeah.
Yes, sir.
So Mayank, beautiful, wonderful lecture, and I think he has covered everything. Just one or two points for the youngsters, especially in cases of malignant glaucoma. When you are doing a posterior capsule, you have done a vitreolysis and then you do a posterior capsulotomy, you still find that the fluid is not coming forward many times. So what we realized, and this happened to us a couple of times, then what we do is you take that capsulotomy right till the edge of the lens. And the moment you do that, suddenly the fluid comes in from there and the chamber deepens in malignant glaucoma. So remember that whenever these things are not happening.
So great input, sir.
Yeah, that's a wonderful tip.
I remember Rajesh discussing with Harsh when YAG laser had just come into RP Center on the patterns of capsulotomies. And I think now with multifocals and the the optics that they create, it's not easy to do a capsulotomy anymore. I think the tip that was discussed was that you should start from the periphery and then try and create a cruciate. That may not necessarily hold true with a multifocal. Sometimes it's very, very difficult to, especially if the PC is plastered to the back. You may want to actually go centrally first and then move outwards rather than the other way around. Posterior defocus or an offset is extremely important in these patients, especially because if you're going to do central first, remember that the first shot that you give tends to deepen the capsule a little bit, and then it makes it a little more easier because the space between the PC and the IOL increases, and you can then actually move around on the edge of the open area to increase the space, because where these zones are, it's very difficult to actually identify where the PC is and to get a good focus. So that was just my comment on the.
So Rishi, that is why I don't like multifocals. And the second thing is, we actually published it also that you have to start inferiorly. And because what happens is when there is a plasma formation, and so many times there is a bubble formation. And the moment you do it initially inferiorly, there is a bubble formation, which actually the bubble rises up and separates out the anterior and the posterior capsule. The posterior capsule and the lens part. And then like Rishi was saying, it becomes so much easier to do it. But Rishi, I'm really skeptical that should you start because you may be a very steady hand, but a lot of our friends may not be having that steady a hand. And if they pit the IOL right in the center, for you it is okay. You'll say, "I change kar dunga." You are an expert. But for
I completely am with Mayank on starting in the periphery first, because even if you do pit the IOL, you'll get away with it.
Mid periphery, I guess mid periphery is a better.
So have any one of you seen pitting there? In a multifocal which required the removal or something like that? I think Titial must have done the maximum.
No.
Anybody?
To be very frank, I've not seen that type of damage to the IOLs, because the lasers, the newer generation YAG laser machines are also, the focusing is very, very precise nowadays. And little bit of a pupillary dilatation sometimes does help to see the posterior capsule better. If you try to do with a small pupil, then focusing sometimes can be difficult in these cases. But as Harsh was saying, thankfully I don't do YAG myself. It's given to the young people. And whatever they do it, they seem to done a good job. But looking into the newer generation IOLs, the posterior capsular PCO requiring the YAG laser incidence is quite less.
Yeah.
As Rishi was saying, maybe with the newer generation trifocals where patient demand is so much, sometimes people do take away the posterior capsule very, very early also. There you have to be very precise and very accurately, hit hitting the posterior capsule in the right manner, and not to enlarge the posterior capsule too big also, because that will also create a problem for these patients. I'm not
think,
sure about how much hyperopic shift would happen in these cases. If it happens in a multifocal or trifocal, then it will be a disaster, because both distance and near vision acuity will get distorted in these patients. But in a Western country, people do YAG laser very, very early in these cases, because the patient demand is too much. Here, we satisfy them with the different things, give artificial tears for long, long time.
I think
But that is
we
important.
do have a large number of patients who have a significant plaque even on table, and in spite of
They
your
do
best
well. They
attempts
do well.
to polish, you will with multifocals especially, they get into that 6.9 partial range, which is largely an unhappy range. I personally don't do YAGs earlier than 8 weeks, and so it's just a nightmare to handle them for that long. With that kind of vision, they're very demanding, and they want an early solution to the problem. I do see a little bit of hyperopic shift, even with YAGs that are not very large. I will hardly ever go outside the multifocal zone, which is typically around 3.5. So I will hardly ever violate the 4 mm rule. And for me, again, with multifocals, you have to dilate. A semi-dilated pupil, without that, it's very tough. The reflections from the lens, from the optical system, the illumination lamps, very tough to actually locate the capsule, and you have to go very slowly.
That is true. I think, some of my patients were a young patient with a posterior subcapsular cataract. The fibrosis does happen if you delay the surgery in these patients. I have few patients. I do, on the table posterior capsular access in these patients, and that will, have a better, lens, effective lens position also. It will not require the laser energy to be diverted to the both, to a angle area, create inflammation, glaucoma, which is the major concern, and the CME. So if you have a thicker plaque, you can plan, if patient is cooperative, do a small, central capsular access. That does help in these patients. As talked about, patient with a higher axial length, myopic patients. Now, we do have a lot of patients who undergo, early cataract surgery or a clear lens fixation in our group of patients with a high myopia. So sometimes I do take these patients for aspiration of a cortical matter surgically, rather than opening the capsule with a YAG laser. Many people don't agree with my way of handling, but I do take these young patients up and open the capsule from periphery and aspirate the cortical, the secondary cortical matter, and leave the capsule clear. And in some cases, I do capsular opening also, making a small primary capsular access of the posterior capsule, rather than actually giving a YAG laser in the young patients.
Yeah, in young patient, we had published one paper also that membranectomy is a better option, because what happens is the vitreous is in gel form. If you do a YAG capsulotomy and the capsule is a little bit fibrotic, so you have to cut it actually. So these pieces, they remain suspended in the central visual axis, and they create problems a lot. And regarding fitting, what I feel that all these things were, I guess, things of the past, when as sir was also mentioning, that we had a very thick fibrotic capsule, we had to use a lot of energy, so it used to happen. Rarely it happens these days, because the patients are so demanding that even 6.9 partial will require a YAG capsulotomy, which will require a very little bit of energy. So I guess maybe that is, and the machines are good with a good offset, so that perhaps is the reason. So
Rajesh, I just want to ask a question to Harsh here. Like, there's a standard treatment for a post-YAG capsulotomy. People give anti-glaucoma, a little bit of anti-inflammatory for all patients. Do these patients have a rise of pressure as such?
Not really. But if they are steroid responders, and if there's an inflammation already existing, or they've had a trabeculitis or something previously, that there's a history, or they are glaucoma patient, then I think we'll be better off trying to put them on one extra medication. But not really, you're quite right. I think the amount, And I think what is basically happening, you are right, is the lenses are so good now. I think your host, because I've rarely seen a multifocal develop a thicker thing.
Yeah.
So I think it is that the lenses rather than anything else that is.
I think
doing
another one more indication of using yak capsulotomy is in trying to remove the rim of the anterior capsule, particularly the nasal anterior capsule in patients with negative dysphotopsia, where it is recommended that the shadow of nasal rim of anterior capsule is casting the shadow. And so there's a lot of published literature. I don't know how many people, how many of us have done that, but it is published as one of the treatment modality for treatment of negative dysphotopsia.
Let's ask Dr. Tityal. They are the stalwarts here. Rishi,
Well,
Tityal, Namrata, Rajesh.
I don't have that many patients with negative dysphotopsia in these patients. And these are normally associated with 360-degree square edge lenses. And fortunately, in the past I have been using more of Acrisoft lenses of IQ design, where the optic haptic design doesn't have a square edge. So normally I put my all lenses 180 degrees, that is 3 nanoclock. The optic haptic junction doesn't have a square edge, and that's the area from where negative dysphotopsia happens. Yes, treatment has been advised in these cases. One is, as Dr. Bhalla rightly pointed out, other people have done a reverse optic capture, getting the optic up in these cases, which may help in some degrees. But I've seen patients who see some sort of images. Whatever you do, the images never go because they have a memory in their mind. They keep looking for those images. So these are more of a counseling appropriately to these patients, and most dysphototic symptoms go off after some time. It is the patient's mindset. There are people with a little bit of symptoms also, they get so much of disturbed. I have removed one IOL with a patient having a just zero point 0.5 diopter cylinder, because patient did have a little bit of blur in the distance and after my life. So these are basically patient-related problems.
Also, sir, I think YAG you also do in capsular distension syndrome, either on the PC or even at the rim of the anterior capsule, and also for desmatotomy when there is a retained Descemet's membrane, especially in cases of PBK, etc., or SCHED, etc. You leave an inadvertent Descemet membrane behind. Then people have done YAG desmatotomy even for that. Sir, I just want to ask you, I want to ask you one question. There are a couple of studies in literature which say that YAG is required more frequently with the diffractive type of IOLs. So what is your experience, sir, in that?
I don't think, that is maybe true now with the newer generation diffractive IOLs, because the outcomes has been quite better now. They were for earlier generation lenses where every multifocal patient had undergone YAG laser capsulotomy, because they thought sometimes the capsule, the little bit of wrinkle in the capsule may be causing a visual disturbances, which was actually not true. It was basically the optics of lens which was causing problem for these patients. So I have hardly done a YAG capsulotomy in my multifocal or trifocal lenses. I think it's less than 5% in 2 years. That's a very good number. And one thing I like to clarify here, what Dr. Namrata was saying, if you have capsular block syndrome, so if you have early cases, like immediate post-op early cases, then opening the capsule might decrease the block syndrome in these cases, both anterior and posterior. But we do see a late onset capsular block syndromes, especially once you have square edge lenses. They prevent the growth of cells coming to the central area, and they keep accumulating beyond the edge of lens. And after some time, these accumulated lens fiber, they become liquefied, and they slowly seep into the central part of the visual axis, and they extend the posterior capsule and also decrease the, you can say, quality of vision in these patients. In fact, if you see some of the cases of ours, you can see the entire, you can see a plano-convex lens type of thing beyond the IOL in these cases, which is quite sometimes opaque also. And we have described the various techniques for that. I published in IGO also, because you can't do YAG in these cases. If you do YAG, the entire fluid seeps into the vitreous cavity and causes severe inflammation. So we have done open the capsule in these cases. In fact, these happen in a normally beautifully done surgeries, where the capsule is plastered onto the lens surface beautifully. So you have to open the capsule, then aspirate these cortical matter and fluid, then do a opening in the posterior capsule. So that prevents a long-term recurrence happening in these cases. So that's a technique we have in IGO, and video is also there. People can see. And same technique we have described for a post DMEC cases, where sometimes do have a similar opportunity. In our DMEC or DSEC cases, we don't like to open the posterior capsule because these patients may require a secondary endothelial keratoplasty in future. If you have an open posterior capsule, things can be difficult. So there we have just described that you have to just aspirate and things will be better. You can maintain the anterior posterior compartment for a future surgery also. So gamut of a posterior capsular problems are there, and they can be handled as Mayank rightly pointed out, the various techniques.
Thank you, sir. So we move on to the next talk, and that is by Dr. Harsh Kumar, and he'll be talking on diode laser photocoagulation in refractory glaucomas.
So, is it clear, the screen?
Absolutely, sir. Yeah. Absolutely, sir.
So thank you, Rajesh and Titian and Namrata for having me here. But it gave me a little bit of a shock when he told me to speak on DLCP because now at this age you have most complicated surgeries and I have videos of all the most very difficult surgeries. So this is something which is very, very basic. But well, that's a challenge. So let's go ahead and see. It's interesting. But it was a pleasure being in such a beautiful session. And I heard things which we have never heard, and especially about that Fevikwik. So that was really fantastic. And I wish they will do some, you all guys will do some thesis on that. So diode laser cyclophotocoagulation is a savior in so many situations. It started way back in 1861 when cyclodiathermy, just burning the ciliary body. So the idea was with the people that if you burn the ciliary body, the fluid will become less and the glaucoma can be controlled. Then came cyclocryo, then the ultrasound, and now the laser photocoagulation and some ultrasound we are going back to at times. But the most important things are the indications. So for the youngsters, please remember one thing, that whenever you are looking at the globe, touch the conjunctiva and see that you may be seeing a particular area having a trab. And you think that all right, nothing more can be done. So touch the conjunctiva with a swab stick and see if it is nicely mobile. If it is mobile in the superior quadrant, one can do even 2 or 3 trabeculectomies. And always, please, I am telling this to all youngsters and practitioners, do not hesitate to refer your patients. Because I have seen that if you refer the patient to the right person and the right thing gets done, then they are so much more grateful to you than if you try and do what is not right at times. And sooner or later, they do come to understand that perhaps it could have been done. So classically, if there is a severe conjunctival scarring when nothing else can be done, that is the indication for doing procedures like this. And we'll be talking a little bit. But yes, if you have a painful blind eye, and you want to lower the IOP and the patient is already on maximum medication, these are all indications where we resort to cyclodestructive procedures. And obviously, classically, neovascular glaucomas with low vision. Now people classically used to do it with low vision. They have started doing it, becoming braver and doing it with greater vision. But let me be very clear with you, if any other procedure can be done, I think you are right in telling that that procedure should be done. It's only if you are in the periphery, nothing more can be done. Yes, please go ahead and do something, because if nothing else and the patient won't go to any other center, then yes, you can do it. So neovascular glaucomas, yes, with low visions, many a times even we have to do it. PK, close to all your hearts, but luckily now with DSEC coming in, things are better. But yes, post PK, doing a trab is hell. And if you want to do a valve, I have seen now enough doing a valve in the anterior chamber is a mess, because sooner or later it will make your cornea fail. So that is not going to work out. To do a posterior valve means you have to have a very good retina surgeon with you and an experienced glaucoma surgeon with you, which may not be easily available. So one has to really think of doing these kind of procedures over there. Again, post-retinal detachment, when they fill it up with silicone, we have a tussle all the time. We say, yaar, oil nikal do, please, the pressure is too high. And they say, nahi sir, if we take out the oil, then again it will re-detach. Then this tussle goes on till sometimes when they really cannot do it, we may have to do a partial cyclodestructive procedure. And again, all inflammatory, all refractory glaucomas where no procedure can be done are the classical thing for this. So initially it started with a ruby laser, but now what we use is a diode laser with 810 nanometer wavelength, because it is the one which affects the melanin in the ciliary epithelium most, and therefore there is the targeted destruction with least collateral inflammation. So mechanism, essentially there is a destruction of the ciliary epithelium, so there's lesser production of the aqueous, and vessels are also damaged, so that again aqueous cannot be produced and there is an inflammation over there. The inflammation itself can actually cause an increase in the transcleral outflow and uveoscleral outflow, which may be transitory, but these are some of the mechanisms. And obviously you have to place your probe around 1.2 to 1.5 millimeters away so that they hit the ciliary processes. That is what we are targeting, and these are the things that we want to target ultimately. And essentially you have to give a retrovulvar or a peribulbar anesthesia, because it is extremely painful procedure. And the duration is around 1200 to 800, 1800 milliwatts. The power, sorry, the duration is 2 seconds, and in each quadrant we can give around 4 to 6 spots, and be very, very careful to give lesser amount to begin with. And so this is how we set up the console, and you can keep varying your power and the timing also. So this is the G probe that we use. And the procedure, basically you have to place the probe 1.2 to 1.5 millimeters away from the limbus, perpendicular to the ciliary body. The eye should be not be wet, it should be dry, and then you press the thing so that the protrusion in the probe goes in a little bit, so that you can be nearest to the ciliary body. You should be hearing a pop. The pop actually means that you have actually destroyed the ciliary processes or the root or the retina or whatever. Something has been destroyed in that area. And but you actually don't want, you want a little less destruction, so go down 150 milliwatts on that. And that is when you actually don't hear you heard a pop, and then you don't hear a pop, and those are the things that you carry on with. And ideally you should do lesser, please, especially for all the youngsters, do lesser. I know of cases where, though the vision was less, the patient said that this was at least my looks were good and all, and the patient goes into phthisis and they have sued the doctor. So please be very, very careful on that. Do lesser. You can always do it multiple number of times, no big shakes. So obviously avoid 3 and 9 o'clock to avoid the ciliary nerves, and any area of thin sclera, etc., filtering surgery, tube, etc., you have to avoid, obviously. So this is the tip of the probe that we use. Be careful not to bend your wire, because some people just bend it up and this whole wire breaks off and you have a mess to pay. And this is that little protrusion in the probe that we have to press it over there. And obviously it was difficult for me to find so this is some ancient thing. So already you can see there's a valve over there. You can see there's a valve over there, but that has also failed. So we resort to this procedure where you keep the lesser probe here and the larger flange posteriorly. And the small spot is made, and the next probe is kept at the edge of that spot that was made. And that is how you keep it pressed till the whole thing is over. and don't remove it in the middle, because you can take the sclera away and there could be mess over there. Keep the thing dry. So this is another almost same kind of a thing, nothing really great to show over there. But very important thing is, many a times you will not hear a pop, and then you are worried, especially in high myopic eyes. In children, the ciliary body could be very variable. It may not be 1.5 millimeter, maybe 4 millimeters away. So you put a light and do a transscleral illumination and see where exactly the dark area is coming, measure it and then do it, and it may be variable in all other areas. So be very, very careful in some of those situations. In standard procedures, you don't need to do it. When you hear a pop, you're good. But if you're not hearing the pop and you feel your energy is already quite a bit, about 2.2 watts or something like that, you don't want to go more than that. So you just want to be careful that you are on the right track, especially in high myopes and disorganized globes, etc. Post laser, obviously, there will be a lot of pain. So please give some strong analgesics and explain to the patient that bhai dard to hoga, there will be pain. And then you give topical antibiotic steroids and cycloplegics. The cycloplegics will shrug off the pain to quite an extent, and continue the pre-laser glaucoma medications till you're sure how much reduction has been achieved. And call the patient the next day to see where are you headed. Additional laser therapy must be done only 6 weeks later, not earlier than that. Be careful to explain and write it down and get it written by themselves, that yes, the eye can become suddenly soft, it can go into phthisis, the pain can still persist with inflammation, there could be hyphema, cataract, high intraocular pressure requiring retreatment, there could be a staphylomas formation, there could be pupillary distortion, there could be corneal edema, vitreous hemorrhage, malignant glaucoma, necrotizing scleritis, sympathetic, vision loss, painful blind eyes. So all the things have to be explained to them, and that is why one has to be very, very cautious in doing it in a seeing eye. Be very careful, like especially in cases of NVG, you can get a hyphema like this, which is actually looking like a hypopyon. And so now there is a newer introduction of a modification of DLCP, which is a micropulse cyclo G6 laser, which again is a 810 diode, but the good thing is that there is an on time and an off time. So it helps to cool down the target in between this and reducing the thermal damage. The thing is that it works very well in some of the patients, but in a whole lot of patients it may need to be repeated. And the probes are expensive, definitely, so that is one drawback. And in many of them, additional surgeries may be required. So it could be a stopgap arrangement, but please remember, again, I have seen enough patients with hypotony, pupillary dilatation, bleeds, RD also by micropulse. So it is not a panacea. So this is one of the patients young patient in whom micropulse was done, came to me with pupillary dilatation and bleeds. The bleeds absorbed where the pressures are very high. So we had to do a trab and then he got settled. Endocyclophotocoagulation is another technique. The machine is very expensive. So basically, but it is good in the sense that you are actually seeing, you're going in, seeing the ciliary process, and then with the help of a probe, you are damaging them, so that it's a very targeted damage. And the collateral damage, the pain, the chances of developing some other complications like hyphema, CME, etc. can occur, but are much, much less. But overall, what I like to tell you that you will have a number of machines available to you. And obviously, please let us not forget cyclocryo. A lot of my friends, and that is the beauty of India, that huge number of our doctors will find ways of treating their patients to the best of their ability. And these machines, which I have told, are 20-25 lakhs. Whereas a cyclocryo, within 10,000, you have the whole system. And okay, the pain will be more, but you are pretty much doing the same thing. And so many of my doctors are so beautifully treating their patients with that. The only trick in a cyclocryo is allow the probe to thaw by itself. Don't put water in it to make it suddenly go away. And don't pull the probe away till it is completely thawed and released by itself, because then it can take the sclera away. So these are the two basic tricks, and again do it partially so that you are not suddenly making the eye go into phthisis. What is very important is don't worry too much about what is written in the publications. A whole lot of publications today are biased by the companies who are actually producing these machines. So ask your friends around, ask people in the institutions, because these are the ones who have not bought the machines personally and are keep praising the machine. They will tell you what is the truth. So get all aspects of a procedure, just use its science. Don't love it or hate it. So just do what is to be done for and what is best for the patient. Thank you very much for your kind attention.
Thank you, sir, for very valuable tips on this important procedure. And once again, thank you for agreeing to present on this topic. And would like to have comments of Dr. Bhalla, who is again a glaucoma, eminent glaucoma surgeon. Dr. Bhalla, please.
Yeah, Dr. Harsh, that was a very nice and exhaustive presentation where you really told us about the pros and cons of these two laser procedures, particularly the diode laser cyclophotocoagulation and the micropulse diode laser cyclophotocoagulation. Although now they can be, particularly the micropulse one, can be considered as another additional tool and the armamentarium for treatment of glaucoma, but we have to be very careful about the facts that these are not, it's not a panacea, it is not a foolproof procedures, and the patients have to be clearly told about the side effects, the complications which are significant. They are not mild complications like hypotony, the chances of phthisis bulbi, corneal graft decompensation in post-PK glaucomas, then the hyphema, etc. And the biggest challenge is the lack of large, well-controlled studies which have evaluated these procedures. So, and another important problem is that the success rate varies from various studies, different studies, because the success rate, the definition of the qualified success and the absolute success is different in the various studies. So the success can be as low as 40 to 50% to as high as 90%. So there is no uniformity. And second thing is that although it is better to use particularly in refractory glaucomas where you find nothing else can be done, and future studies are required where they really determine the ideal parameters and further modification in the present protocols. Particularly now in diode laser cyclophotocoagulation, I could come across two types of the procedures have been described. One is the slow coagulation type, where you use about 1.25 watts for 4 seconds compared to the standard technique where you use 1.75 watt for 2 seconds. And so the energy delivered is different in the two, where in one it is 5.5 joules, another it is 3.5 joules. So I just want to ask you, is there any difference in the complication rate between these two types of procedure, where slow coagulation or the standard type? And what are your views about, do you think that the micropulse cyclophotocoagulation has totally overrun and made the diode laser cyclophotocoagulation almost obsolete as a procedure in seeing eyes?
Thank you, Dr. Bhalla. That was a wonderful question because I actually didn't go into it, but yes, you're right. The slower coagulation is better, and we have actually shifted to the timing range of 4 seconds. So that gives us slow coagulation, and our rate of complication seems to be much better with that, but though obviously we don't have any written material on that. And unfortunately, or fortunately in a manner, we do very few of them, because most of them we manage to do either a valve or a posterior valve. It is rare for us to get into these kind of situations where we have to do a diode laser cyclophotocoagulation. But yes, slower coagulation thing I think would be a better procedure.
Better all.
As far as the micropulse, again, you know what happened, like in my last slide, I said don't love it or hate it. What actually happened was that the company was pushing it as a panacea for, and they told people, no, तुम्हें trap करने की ज़रूरत ही नहीं है. You don't need to learn trap. This is a procedure for, this is a trap in a way, which you do in 5 minutes and you are done. That really bugged me off terribly, you know, because it is not that at all. When would you have a phthisis bulbi in trap? I don't think anyone would have, of you would remember. And you must have seen thousands, all of you. when would you see a hypotony to that extent, or if you would see a detachment? So these kind of complications which can also occur with micropulse, one must remember. So rightly what you said is, please use it where you have to use it. It is not an alternative for any of these better procedures, definitely. So please don't use it. And later, sooner or later, other people started realizing it. I think even my friends in institute later told me, yes, we tried a lot and we now realize what are its limitations. It is a slightly more sophisticated diode laser cyclophotography. That is what it is. So please, if you are using it in seeing eyes, be very, very careful.
Exactly. And on top of that, the published literature also says that more than 12 to 13% of the patients also have vision loss of more than 2 lines. And this is more in patients who have already, the vision is less compared to the patients who have better vision. I could not find what is the cause of diminution of vision in these patients. You are just decreasing the intraocular pressure by causing destruction of the melanin pigment in the pigmented ciliary epithelium. I would like to have your views on that, and also what is the cost and how many times the probe can be used in these procedures.
So as far as the DLCP is concerned, classically all these people say that use the probe only once. But you know, like Indians, we are the most masterly people. So we use it till the pop can be heard. When the pop cannot be heard, then we know that the probe is gone and we have to buy another probe.
Another probe.
That is one part. And the cost of the machine, like I already told you, is around 20 lakhs, which is hell of a lot. So I still know that a whole lot of people in the periphery are still using the cyclocryo and doing a good job about it. I think somebody in the panel wanted, Rishi, you wanted to say something, I think.
I was just I was recalling the comment that you made about cryo, and how just recently I was in a seminar where they were talking about how obsolete cyclocryo is and it should never be used. And I was thinking, within 15 days, I'm hearing these opinions about cyclocryo, something that I've grown up with, and I still believe it has a role to play tremendously.
10,000 thing, man. Who can buy
My other question was actually the thing about not doing the 9 o'clock, 3 o'clock area. Is there a pain issue, or is it,
No, it is basically because the ciliary nerves and the vessels going there, so we just want to save them.
That's just about the only reason.
Pain is much more, and the more chances of phthisis. They say they avoid these areas of 3 and 9 o'clock, and the area where trab is there or scleral thinning is there, or area of the glaucoma drainage wall. These are the sites which should be not touched while doing DLCP or micropulse DLCP.
And the point about transillumination, I think, is extremely important. Because otherwise you're shooting in the dark.
Right.
Okay. So thank you, sir, for very nice presentation and very good discussion. So we move on to the last talk, and that is by Dr. Srinivas Joshi, and he will tell us about a very important procedure, and that is intravitreal injections in post-op endophthalmitis. So we have this young and dynamic retina surgeon talking about intravitreal injections in post-op endophthalmitis.
Thank you so much, Rajesh sir, for this kind invitation, and happy to be amongst all the eminent speakers and the panelists here. My namaskars to Namrata madam and TPL sir, Harsh Kumar sir, and all the speakers and the panelists of today. So I'll be speaking on the management of endophthalmitis. It's basically on the intravitreal injections. So how do we differentiate it from the TAS? That is very, very important. And we all know that TAS is basically a first and the second day affair, where there is end-to-end corneal edema, hypopyon, but there is absolutely no vitreous involvement, and they usually respond good to the steroids. So we need to strongly suspect infection if the reaction is out of the proportion to the surgery, and the hypopyon occurs after 2 to 5 days, poor response to the intensified treatment, vision grossly reduced, Patient has pain and the lid edema, and the B scan shows the with echoes. I think this is the most important point in differentiating the B scan to know if there are any with echoes. If they are there post-operatively, then it should be considered as endophthalmitis unless proved otherwise. So the role of the USG, that's the B scan which I was talking about, it's important to know the status of the retina, whether there is sometimes a choroidal detachment also happening, or sometimes there can be only a PVD with the membranous verticose, or sometimes there can be a retinal detachment also. So these are important to know the status of the retina, the verticose, the PVD status, and the T sign. It's very, very important to know if there's also having the subtenon fluid, what we call it as the STF, and the IOL position, whether it is in place, displaced, dislocated, or decentered. So usually it presents as, we call it as a fulminant if it is less than 4 days. Usually it's a gram-negative Staph aureus or the streptococci. It's acute if it is between 4 to 7 days, and the causative organisms most likely is a Staph epidermidis. And it's called as chronic if it is more than 4 weeks. So it could be due to the delayed entry, that is the bleb related, or delayed onset, usually due to the P. acne fungi or Staph epidermidis. So the most common organism responsible for endophthalmitis, as we all know, is 75 to 85% is gram positive, and 10 to 15 is gram negative. And the leading is the Staph epidermidis, which accounts to nearly 43%, and then comes the Streptococcus and the Staph aureus. Whereas the Pseudomonas is more common in gram negative kind of bacteria, and the Proteus and the H. influenzae. So now coming to immediate PPV versus tap and inject. When to look into these aspects. This is I think a most important thing which we need to decide. In the EVS study, the patient who presented with LP only visual acuity had a significant, that is 3-fold improved chances of obtaining 20/40 vision after immediate vitrectomy, that is around 33% compared to tap and inject, which was only around 11%. And 56% of obtaining 20/100 or better after immediate pars plana vitrectomy compared to 30% when you do only the tap and inject. And hand movements or better vision or no significant difference between the treatment groups in the final visual acuity, then we have to consider earlier PPV, especially for diabetics. Now coming to the systemic antibiotics, there is still some people say there is a role, some authors say that there is no role, because usually it is too slow to enter the eye in adequate concentration, especially when we use it only for a monotherapy. In the EVS, there was no difference in the visual acuity or media clarity with or without intravenous antibiotics, that is amikacin plus Cefta or amikacin. But we need to remember that EVS is a pretty old study now, and the threshold for treating these endophthalmitis has become very low nowadays with the invent of the MIVS and the skills of the surgeon and the improved instrumentation and the machines. And at that time, we did not have the 4th generation fluoroquinolones, which usually have a better ocular penetration. And therefore, systemic ceftazidime, cefazolin, ciprofloxacin or gatifloxacin and even moxifloxacin have shown to have a better penetration into the blood ocular barrier. There are certain EVS limitations, as I said before. Along with that, the EVS results may not apply to endophthalmitis after other ocular surgery. That is, it's only studied only the post-cataract and IOL surgery. So for example, post-intravitreal injection, bleb-related end-off, or chronic post-op end-off were not studied in the EVS. And patients with no light perception or significant opacification of the AC, which obscures the iris tissue, were excluded from the study. This is an important point. Therefore, the severe infections or virulent organisms were removed or excluded from the study, and it cannot say anything more definite or concrete about these end-stage diseases, of course, which definitely requires surgery. The role of corticosteroids, again, it's a double-edged sword. The goal is to modulate the host inflammatory response, avoid when fungal infection is suspected. So intravitreal corticosteroid is still controversial, and I think we are coming up with a new study, and we gave the guest editorial about this corticosteroid. I feel that if you know that it's not a fungal, if you are very definite about it to be a bacterial, it's an acute bacterial inflammation, and you can do a good kind of vitrectomy, you can remove the good amount of the vitreous, induce the PVD, In those cases, I think dexamethasone can still be considered, and I have seen a very good results in those cases when I have operated in my own armamentarium in our institute. So another retrospective non-randomized trial showed that it showed worse visual acuity. There are studies which shows that it has good visual acuity. As I said, it is still debatable. So the surgical option actually depends on the clinical scenario, that is predominant AC reaction, vitreous involvement, or combined. So this is in case where there is hypopyon with good glow. So what a comprehensive surgeon can do, he can definitely do an AC tap and intensify the topical treatment. He can in fact start the systemic antibiotic also if required. And the most important thing here is to monitor 6 hourly. So as I said before, treat as endophthalmitis unless proved otherwise. This is a very, very important dictum. So coming to this another case where post-op endophthalmitis, 3 weeks after surgery, the AC wash was done and the vitreous was relatively clear. Here you can see there was just a membrane. So these membranes were removed and finally intracameral injections were given and the vitreous was clear. So the final visual acuity in this patient improved to nearly around 612 in this case. So in case of wound infiltration with the AC reaction, membrane removal is definitely important. AC wash, betadine intrastromally, I think the first lecture, few lectures explained very well about it. And definitely in these cases, it's always better to give a prophylactic intravitreal antibiotic also in these cases. So this is again just involvement of the anterior segment where there were membranes, but hopefully the posterior segment was not involved. So intravitreal injections was given at the end and the patient did really nice in this case. So coming to the next is posterior segment involvement. So what I tell to my residents and the fellow is follow ABCD rule. So A is the antibiotics to be given intravitreally. D is the betadine wash. C, instead of constitution, you can consider as reconstitution, and D is dosage, distance, direction, and decompression. So posterior segment involvement, vitreous tap for gram stain, KOH, and the culture is very, very important. Intravitreal antibiotics generally empirically covering the gram positive and the gram negative organisms. Antibiotics which to choose, gram positive, the most favored are the vancomycin and the cefazolin. Gram negative, it's amikacin, gentamicin, and ceftazidime. However, carbapenem's broad spectrum antibiotics for resistant end-off cases, you can use the imipenem, meropenem, dose is around 100 microgram in 0.1 ml. There are others like piperacillin, carbapenicillin, or aztreonam. So the preferred empirical regimen is Cefta plus Vanco, Amica plus Vanco, or Cefta plus Vanco plus or minus moxifloxacin. The only thing is care should be taken, avoid mixing of the drugs which might get precipitated. Example, vancomycin and ceftazidime, giving it in the same syringe is definitely not advisable. Now most of these are NABH accredited institutes and many of the institutes have their own antibiogram. So we have our own antibiogram in our institute and our most preferred is A plus M, that is amikacin plus moxifloxacin. In case of fungal, then we use the voriconazole or any other antifungal element. So other one antifungal is apart from voriconazole is amphotericin, that is 5 microgram in 0.1 ml, but the most favored is the voriconazole, which is around 100 microgram in 0.1 ml. So B is the betadine wash. We all know that betadine wash, in fact, any patient, when I was studying my fellowship in 2011 to 13 in US and Canada, the patients who were telling that they were allergic to povidone iodine, many of the surgeons in fact defer to give injection in these cases. So while giving intravitreal injections, I think the betadine wash is very, very important, and it has a broad antibacterial effect, and it decreases the conjunctival flora to growth nearly around 91%. And it can, many of the couple of the studies, including the meta-analytic studies in the Europe, has shown that it can kill the conjunctival bacterial flora in nearly around 30 seconds. So povidone iodine definitely is a very good tool, especially when we are giving intravitreal injections, when we are giving it for ARMD, diabetic retinopathy, or many other routine cases. Constitution or the reconstitution, ceftazidime, I'll not go into the detail. Most of us already have it in our OT, and we follow it very regularly. The last one I would like to show is about the procedure for intravitreal injections, that is direction, distance, decompression, and the dosage. I've already covered about it. So giving a good wash is the betadine scraping is, painting with the betadine is important. And in case of phakic, it's important to mark, use a caliper, it's around 4 mm. And in case of pseudophakic, it's around 3.5 mm. So it's always better to use the caliper. And now you can see I'm using a 30 gauge needle here and trying to inject it. So once you give this injection, you can definitely, here you can see some people prefer to change the needles or inject 2 or 3 times, but there's also like you can remove the syringe from the hub and you can use the same port and try to inject. And once you do that, either you can do a decompression before or after the injection, but I prefer to do it before, especially if the patient is also having a glaucoma suspect or the borderline. We don't want to unnecessarily increase the pressure. So decompression is very, very important, and I prefer to do it before the injection, and then you can give the injections later on. So the P. acne, the treatment options with recurrence rates, you can see here, antibiotics alone has a recurrence of 93%. When you combine with the pars plana vitrectomy with antibiotics, it's around 50%. So the 0% is only possible when you have around PPV plus total capsulectomy, IOL removal or exchange along with the intraocular antibiotics. My last slide is in case there is a clinical suspicion of endophthalmitis, then it's a very good study. I just took up this picture for every one of us to know, for the general ophthalmologist and for as well as the students. Adequate visualization of the retina is there, visual acuity, hand motions are better, or if there's a suspected intravitreal injection associated endophthalmitis, or in case of clinical suspicion of traumatic fungal or web related, then it's always better to do a vitreous stab. So do an intravitreal antimicrobial therapy and consider intravitreal dexamethasone. As I said, if it is not fungal, then only you can consider it. Systemic fluoroquinolone can be started. Close observation. Pars plana vitrectomy if no improvement within 1 to 2 days. So that's very important. In cases where you have light perception or clinical suspicion of traumatic fungal, then directly jump into a pars plana vitrectomy. Refer it to a vitreoretinal surgeon. He will do a complete pars plana vitrectomy, use the antivitreal antimicrobial agent. And as I said again, consider intravitreal dexamethasone based on what kind of KOH positivity or negativity you get. Add silicone oil intraoperatively if there is an extensive necrosis or retinal detachment. If the endophthalmitis occurred more than 6 weeks after the intraocular implantation, sorry, then capsular plaque suggestive of P. acne. As I said in my last slide, it's always better to do a central capsular and intravitreal vancomycin and intraocular lens removal and sometimes even bag removal also. So summary, early diagnosis, accurate clinical and B scan is equally plays an important role. Timing of the vitrectomy is very crucial. Modify the vitrectomy technique and appropriate antibiotics. So they say that never lose faith, because if plan A fails, there are still 25 alphabets. Thank you very much.
Wonderful. Very nice presentation. It was such an important topic and so nicely covered. Thanks a lot.
Thank you, sir. Thank you very much.
Dr. Abhishek, for your comments, please.
Rajesh sir and Namta ma'am for making me part of this webinar. I think Srinivas sir has very extensively covered the whole topic. But what I want to say that I'm from Bihar, and right now we all have heard about this this Muzaffarpur Eye Hospital. I think in that what we felt is that right now MIVS has taken up for endophthalmitis as the first treatment of choice, and the tolerance for even for a very slight haze, we just go for vitrectomy as a vitreoretinal surgeon. But intravitreal antibiotics are there, and there is a very important armamentarium, and every ophthalmologist should use it. It just not only buys the time, but it also helps in extensively destroying the inflammation or the disease producing organ per se. Regarding this, sir, also I just wanted to. There are two aspects. One is the fulminant endophthalmitis, and another is the delayed onset endophthalmitis. Many of my friends present that they have a case in which the eye was relatively silent for 3 or 4 months, and now it comes with repeated some amount of AC cells and vitreous flare, and then they put them on topical steroids, and then it resolves, and then again after some time it keeps on coming. So we all know that it's P. acne, and or almost in 70% of cases, or sometimes fungal. So in that case, as sir has rightly said, that the the best treatment is that you go for a total IOL removal or and in total capsulectomy. But if some persons are reluctant, then when you are giving the intravitreal antibiotics, just try to penetrate the capsule. Intracapsular antibiotics might work also in those cases. And regarding the fulminant and the fulminant which present very early, like 2 or 3 days, in those cases, mostly it's gram-negative bacteria. So in those cases, since whether we are using the Vanco or the Septa, most of these are off-label drugs. I think in those cases, we should now get open to more potent antibiotics like imipenem or piperacillin or tazobactam. Regarding this cases of Muzaffarpur Eye Hospital, in which we almost lost 30 to 40 eyes, if we had given piperacillin or tazobactam, might be we would have been able to buy some more time and actively intervene. That is what I wanted to say.
Thank you, Abhishek. Thank you for your valuable inputs. It was a wonderful webinar with very good presentations.
Can I ask one question? There are cases. There are cases in which we have corneal ulcer, and along with we do a post-operative, ultrasound, and then we see endophthalmitis like picture. What is, sir, your management in those cases in which you are planning it for penetrating keratoplasty? Do you do the combined procedures, or do you just give intravitreal antibiotics?
You are asking
me or Dr. Srinivas?
No. I mean,
in general, he's asking.
In general, okay.
So I'm sure if you send it to if you send it to Srinivas, he will not give a intravitreal with a corneal abscess. Isn't it, Srinivas? A blind intravitreal you will not give.
Yeah.
The corneal abscess. So I think what we do is that we then put a temporary K-Pro, remove the cornea, and then do a vitrectomy, and then do a therapeutic keratoplasty along with it.
Yeah, I guess that is definitely one option if it's quite a severe corneal ulcer. But if it's an abscess, little bit of abscess, and then there is a significant posterior segment infiltrate, I guess we may still go ahead with an intravitreal antibiotics and do a medical management for the corneal ulcer. I mean, it depends on the severity of the case. If this case is very severe and the corneal ulcer is very severe, then in that case we may go ahead and cut it.
Actually, that is what I wanted to ask, sir. In that many cases of corneal ulcer, we have some borderline inflammation. Like you can say that it's, but what is the tolerance limit, or you just always go for? I mean, I can ask Srinivas.
Okay. Now I could figure out what you want to say is that if there is a corneal ulcer with a little bit of posterior segment inflammation, I guess in that case we should go ahead with only these medical management which will take care of the inflammation. Dr. Srinivas, your comments on that?
I think I would, if it's a unicameral eye, that means if that eye is aphakic, then you have to treat it very differently, because then it's the same chamber. I mean, then you must go into the posterior segment. I think you can't treat just the cornea.
Actually, the borderline kind of a thing is something which sometimes you do get little reflections from the part of the vitreous. You have to be sure that it is really involving the posterior segment.
So there are two aspects to it also. Another aspect is that most of these cases which do have actually end off also are on the verge of thinning or impending perforation, and in that case again retina surgeons will not give intravitreal injections.
So I think in these cases it's better to do a therapeutic PK, madam, or do a patch graft or something like that. And definitely intravitreal injection has to be given if there is a vitreous involvement. That is, I would like to say that having a good corneal surgeons like you all and you trying to do something, I think retinal surgeons are very bold nowadays, because we are very sure that you will do something to make it like a scaffold or try to give it, because intravitreal injection plays a very important role when the vitreous involvement is there, because it's just going to increase if not treated, and especially if there is with the corneal ulcer or the corneal abscess, it's definitely going to go worse. So I think I agree with the panelists here, doing a temporary K-Pro, or if it's a small patch, then if it's a thinning, if there is ectasia, and if the impending perforation is there, it's always better to do a patch graft and then going for the intravitreal injections. And serial monitoring of the B scan is very, very important in these cases. Because sometimes we have seen the cornea goes off, vitreous improves, and after some time, again the vitreous starts getting involved in that point. So better in those cases is to do an early vitrectomy when we have a good visualization. We have a good visualization through the cornea. It's better to do an early vitrectomy because it's going to debulk. And we all know the vitreous is the culprit here. So going to do a good debulking vitrectomy and then give a intravitreal injections, I think that fares more better in these kind of combined cases.
How much is the role of these core vitrectomies? Because these days people don't do core vitrectomies. That's what.
Once we go inside, sir, there is, I think,
have to remove
terminology of
everything.
the core vitrectomy is dying down.
Yeah.
Once we go inside,
So you have to do a complete vitrectomy.
Yeah, complete vitrectomy. Yes.
Yeah, and then you inject intravitreal antibiotics.
Intravitreal injections, and if there is a severe kind of necrosis or those kind, it's always better to use a silicone oil. And I have seen in most of these cases of silicone oil, you are also trying to postpone the happening of the retinal detachment. That's another important point. So I feel in moderate to severe cases, I just put silicone oil. I know some authors might not agree with that, but I have seen silicone oil giving dramatic results. You can always remove it once the inflammation or the infection subsides.
No, but silicone oil filled eyes do not have infection. I mean, that is what, or maybe you know it better, but that is what is general belief, that if you put in silicone oil, then the chances of infection of recurrence are far less.
Yes, it is less, but it's not like it's a complete cure. But the only thing is, under silicone oil, our dosage becomes half. If we are using around 1 milligram or 2.25, then our dosage becomes slightly lesser in the silicone oil fillers.
Okay, so it was a very nice discussion on a very pertinent topic, and I would like to thank all the speakers and the panelists, and I will request Dr. Tityal sir to make the concluding remarks. Already.
Yeah, I think we had a wonderful discussion, especially listening to other people. Apart from the corneal surgeons, we had a retina surgeon, glaucoma surgeon. And that makes as I said in the beginning, very comprehensive session. And towards the end, talking on something which people don't really discuss in our various forums, these basic things. And we need to have a forum, and I think you have taken a right step to discuss these small points, which makes the big change in the ultimate outcome. I think these things also needs to be discussed in a proper forum, and very glad that I could listen to all of you, and it was wonderful to listen to all small tips, refreshing for all of us. So at this stage, we don't do these procedures, but yes, we did. Thank you again for making us wiser today.
So in the end, I would like to thank everyone, all the speakers, the panelists, and of course our team, the admin team of Bageshwar and Anil. So thank you very much, and a very good night to all of you.
Thank you, Rajesh.
Thank you so much.
Thoroughly
enjoyed 2022.
Yeah, happy New Year.
Yeah, happy New Year to all.
Thank you,
sir.
Thank you so
Thank you,
much.
everyone. Thank you, Dr. Rajesh, Dr. Namrata, Dr. Tityal, sir, and happy New Year to all of you, sir.
Thank you, Dr.
Thank you.
Thank you, ma'am. Thank you, Dr. Harsh.
Thank you, Vana. And I think you have got 3 thesis topics now.
I have already got.
एक राजेश और एक डॉक्टर टिटियाल के लिए छोड़ दो भाई. तो एक ग्लू का हो गया, एक वो हाइपरोपिया का हो गया, और एक और भी था कुछ. हाँ.
Very quick.
एक तो DLCP पे I have not asked for anything, but yes, DLCP, because Tanuj is so fond of doing DLCP and all that.
Yes, now I think that.
Are you off from the